Hello, everyone. It's wonderful to be here virtually with you all. My name is Eric Rafla-Yuan. I am the Gene Spurlock Congressional Fellow for the American Psychiatric Association and also a voluntary assistant clinical professor in the Department of Psychiatry at UCSD. Today, we'll be talking about something that really matches the theme of the conference, which is alternatives to police. And the theme for our discussion today is psychiatric emergency response and how we might shift from threat control to treatment. And so to do that, first we're going to talk a little bit about some expectations and then do a little bit of history. So if you just think quickly to yourself today, who would you call if a patient, a friend, a family member, yourself was having a heart attack or a stroke or something like that? Who would you expect to respond and what would you expect they do? And similarly, who would you call if a patient, friend, family was having a psychiatric emergency? And who would you expect to respond and what would you expect they do? And how do those differ? And so going to some history, prior to the 1970s, and later than that in most places, police and sometimes coroners or funeral home staff responded to medical emergencies. Police would transport patients in their police cars or vans, and funeral home staff would use hearses. And basically, the only thing that they provided was transportation. So if you called for emergency aid, they came and they picked you up and they perhaps drove you to the hospital, and that was it. And the medical world also didn't really consider those individuals in need as patients until they got to the door of the hospital or clinic. So until you got there, you were on your own. And so how did we get from there to the understanding and standards we have today for EMS? And so let's go through some history. Here's a timeline from the evolution of emergency medical services in the US. And so we'll start off in 1966, the National Academy of Sciences released a report titled Accidental Death and Disability, the Neglected Disease of Modern Society. And it focused on the growing number of people who died before reaching the hospital. And a significant number of these deaths were related to automobile accidents. And that itself was a function of the growing number of highways that were built after the Federal Aid Highway Act of 1956. And this report, so it really stemmed from the growing concerns of physicians and researchers and called on Congress to create a national emergency system to help deal with these emergencies. Also around that time, ASAP, the American College of Emergency Physicians, was formed. And in 1973, Congress did eventually act by passing the Emergency Medical Services Systems Act. And so that both mandated and funded nationwide infrastructure, including dispatch systems. And both the mandate and funding are important to note, because without both together, implementation would be a patchwork of different systems, with some areas likely having none at all. And so one of the things that I did with some of my colleagues was compare the Freedom House model, which we'll get to a little bit, and how these emergency services developed and how they apply to where we are today. And so Freedom House is a remarkable story. So this is actually a picture from the Freedom House archives at the University of Pittsburgh. And so Nancy Caroline is here pictured on the left, and she is a critical care physician, and a Freedom House medic is on the right. And so in the 1960s, police were deprioritizing and not responding at all to calls for medical emergencies in Black neighborhoods. And so that part of the story was not unique to Pittsburgh, unfortunately. But what is special here is that the Black community and Black community leaders, including James McCoy Jr., who was a local NAACP board member and also president of a nonprofit organization called Freedom House Enterprise, partnered with physicians to develop their own community-based solutions. And so what Freedom House essentially was a Black-run social service nonprofit that attempted to help community members find employment. And so they partnered with the University of Pittsburgh and a world-famous anesthesiologist there named Peter Safar, actually, who invented modern CPR protocols. And so when approached by Freedom House, he decided it was an ideal opportunity to put his new CPR resuscitation methods into practice. And a few years later, Nancy Caroline, who's pictured here, joined as the medical director. And then what came next was what led to the model that we have and we know today as the EMS model. And so what Freedom House did was they trained previously unemployable Black community members as professional medics. And unemployable really should be in quotes. And so these were people that society perhaps had forgotten about or moved on from and thought that were not able to be productive members of society. And so Freedom House was actually able to take community members that had been previously designated as unemployable and train them with the very best practices in CPR, EKGs, intubations, how to administer medications, and all of this in the field, something that had never really been done before, in the civilian world at least. Some of this had been going on in the military, but not in the civilian world. And an actual aspect of the 1966 Academy report was that if you had an injury on the battlefield, you had a better chance of surviving than if you had one in the United States. And so Freedom House actually had such good successes that it became the best model in the nation, the model that we know today. And they were asked to demonstrate at programs around the country. In Pittsburgh, actually, police requested that Freedom House would respond to medical emergencies in white neighborhoods because they realized how good they were. And importantly, it led to a new standard of care: professional clinical teams trained and equipped for responding to clinical emergencies in the field. And so now, if we return to 2022 and we think about the EMS world, if you call 911 and you have a medical emergency, paramedics, EMTs, and ambulance with equipment will arrive and be able to assist you in the field and perhaps get you to where you need to go if that's an emergency room or somewhere like that. But if you have a mental health emergency or something where a clinical specialist could be indicated, police are often the default responders for the large majority of these across the country. And there are a number of things wrong with this picture. But one of them is demonstrated in a LA Times article from this past weekend, where Isaiah Cervantes, a 25-year-old Hispanic man with autism, was having difficulty. His mom called 911 to try and get him assistance getting to the hospital. Police arrived, and shortly after, they shot him. And he was unarmed and did not have a history of violence. But none of this really sort of mattered, because one of the things that we're seeing repeatedly is that if the only tools you have are your weapons, then that is what you rely on. And so one of the things that has really taken off is additional training for police, co-responder units, mobile crisis teams, and other sort of alternatives. So that's really where we get to the theme of this conference. And so one of the things, going back to that New England Journal of Medicine paper that me and my co-authors talked about, was about how intersectionality happens and how that really increases the risk for poor outcomes when individuals with mental illness, specifically minority and Black individuals, are seeking emergency psychiatric aid. And so we know that looking on the left side, if someone has a untreated psychiatric illness, they have a 16 times higher likelihood of a poor outcome if they have a police interaction. And we know that individuals with minority backgrounds, and especially Black men, have worse outcomes when police respond. In fact, death at the hands of police is in the top 10 causes of death for young Black men. And so when you have someone with high risk from both categories, so a Black or Hispanic man with mental illness, and the intersectionality of that means that these individuals are at exceptionally higher risk for that compared to someone else. And so if we're able to get decouple mental health treatment from policing, we advance equity in both domains for all of these groups. And that happens in a number of ways. One, anyone with psychiatric illness who needs emergency assistance would benefit from having a clinical specialist. And then also minority individuals and those seeking services don't have to go through police to get them. But where we are today, we have an exciting new opportunity, and this comes in the form of a national 3-digit calling code. So similar to 911, 988 was passed into law by Congress 2 years ago now, and it will serve as a 24/7 nationwide hotline for psychiatric emergencies. And so this number will replace this current suicide prevention lifeline, which is the 1-800 number that you see above. The question that remains is what resources are available if someone calls 988. And so a couple of things also to go over here is that it's up to each state to implement infrastructure and services. And so depending on what state you live in, the services you'll be able to access will be different. And depending on what county you live in or city, in some cases, it will be different. And so because there's been so much variability, SAMHSA has released guidance on what the crisis spectrum of care or crisis continuum of care should look like. And there are a number of terms that come up here. So I'll do a little bit of defining. So on the left, you have someone in crisis, and that person calls a crisis line, soon to be 988. And that could be the person themselves calling, it could be a family member, it could be a friend, even could be a bystander. And so it's called a crisis line. And per the SAMHSA model, the crisis line should be manned 24/7 with individuals who are trained to triage that call and maybe even resolve that over the phone. And if not, are able to dispatch a mobile crisis team. And there are different models for mobile crisis team. Perhaps the most widely known is one that was popularized in Oregon by a team named Cahoots, which has a mental health specialist and a medic or EMT. But there are other versions of these. Some they use peers or other types of paraprofessionals. And so the mobile crisis team is able to respond in the field as a first responder rather than an ambulance or a police car. And then the mobile crisis team may be able to resolve the need in the field. But if they're not to, then if they're not able to, the next step in this continuum is a crisis facility, also known as crisis center, crisis stabilization unit, crisis receiving facility. And so the idea of a crisis facility is that it's a safe, supportive, home-like environment that's not a jail, it's not an emergency room, it's not an inpatient unit, it's not a hospital, but rather one of the first of its kind, which is a facility or center that's really been specifically designed for individuals having a mental health crisis. So when you think about the emergency room, it really is not a good place for someone having a crisis like that. Neither is a jail or most of the other places where folks can get taken. And so the point of a crisis facility is to safely stabilize the immediate emergency. Often that's getting the person out of the situation that they were in. These are not really residential facilities. The idea is that they're very short term, a number of hours up to perhaps 1 or 2 days at most. And then the other main emphasis of a crisis facility is connecting the individual need to resources so that the crisis doesn't just repeat again when they leave. And so that post-crisis wraparound is really important. And so what some of the preliminary studies looking at this continuum has found is that there's decreased use of jail, decreased use of EDs, decreased inpatient bed need. And also additionally, it's been remarkably effective for diverting individuals with mental health crises out of the criminal justice system. And so that's what that sort of parallel images below are. So ideally, if someone calls 911 and it turns out it's something that would be more appropriate for the crisis line, 911 should have the ability to, or it would be beneficial if 911 operator could transfer the call to the crisis line. And if a police car happened to be the first person on the scene, rather for whatever reason, maybe they were mistakenly dispatched first, and it turned out when they got there that really would be better suited for a mobile crisis team. Maybe they just came upon the situation when they were out, but the police unit could tag in the mobile crisis team if needed. And then another important thing is that these crisis facilities really should have a no wrong door policy, meaning that police or anyone who has someone in need should be able to bring that individual to the crisis facility. And the crisis facility staff should have the capability to manage it there, or if not, to get them transported or referred to somewhere where they are more appropriate for. And so 988 and that crisis continuum of care represents an incredible opportunity to decouple some of these things. And so one of this van here is a picture of the Cahoots van from Oregon that I mentioned. But from an outpatient perspective, you'll have reliable 24/7 treatment-focused emergency psychiatric services. And no longer will clinicians be reliant on 911 and law enforcement to triage and manage patients' acute symptoms. For someone who works in the emergency room setting, perhaps there will no longer be hallways lined with gurneys of patients waiting for psychiatric hospital beds. And for those patients who do need a psychiatric hospital bed, perhaps there will be less waiting for them and easier bed availability. And so in review, 988, the number itself represents an incredible opportunity to decouple our crisis response system from police response. But this will only be realized if the crisis spectrum is fully implemented. And so that means each step in the spectrum. So if you don't have the mobile crisis team, then if the crisis line can't handle it, then they just connect you. They either call 911 themselves or tell the person to hang up and call 911. And that really doesn't get us very far. And if there is a mobile crisis team and no crisis facility, then what this means is that we'll just bring even more people to the emergency room and we'll have even longer waits there. And so really you need this whole system for it to be effective, each piece in the system for it to be effective. So next steps. So remember at the beginning of the talk, we mentioned how EMS got both a mandate and funding from Congress in 1973. And without it, there would be a patchwork of systems and in some places, nothing at all. So this is where the challenge remains for 988. And so making sure that those comprehensive crisis services have both funding and the support needed to be implemented so that calling 988 is a real alternative to calling 911, meaning that if you call 988, you know that someone will be there, that there will be a response if you need it, and that there is somewhere to go, similar to how you call 911. If you call 988 and it just routes you back to 911, if you need anything more than a 3-minute conversation, then that isn't much of an advance at all. And so looking ahead, there's a lot to get done. And so one of the things that I do here in DC is work with some of the legislators to review some of the evidence for how we can best implement these services. Advances are also needed in the dispatch and safety protocols, meaning how 988 will interface with 911 and police, so both on the technology side as well as on the dispatching and routing side. And it's also important to note that the best practices at this point use a triage system, similar to how when we have someone who needs hospital care, we want them to get to the least restrictive level of care, meaning the level of care that gives them the most level of services with the least level of inconvenience or restriction. And so similarly, we can think of getting emergency services and police like that. So for service situations where it can be handled over the lifeline or the 988 line, then that's ideal if that could be handled that way. And if they send for situations that need an on-the-ground response, sending that mobile crisis team. And then for situations that perhaps do need law enforcement there to safely manage the situation. And the most common situations that come up for that are not necessarily the danger, but getting someone involuntarily to a hospital, meaning if someone is put on an involuntary psychiatric hold, actually physically getting them to the hospital. So that's sort of the number one need that's come up, not necessarily that there's a weapon. But if there's a weapon or other safety concern, then perhaps that is the time to send in the CIT trained police team, which is crisis intervention training, or to send in a co-responder model unit, which is often a police officer and a mental health clinician in a 2-person team. Additionally, developing the new workforce for these 988 systems, so both the call centers, the mobile crisis teams, as well as the crisis centers and standards and education for those workforces. And so actually a fun fact, EMTs didn't exist in the civilian world before 911 and EMS. And so there may be a possibility of something like a psych EMT for 988. And so these are things that are being looked at. And so, however, a lot of work to go. And so I want to leave you with some final conclusions. So one of them is that individuals with psychiatric illness deserve an appropriate and effective clinical response. And we would expect nothing less for other kinds of medical emergencies. 988 offers a once-in-a-lifetime opportunity to decouple crisis response from policing. And simply shifting away from a police-first response advances equity for many groups, who for a long time really have been poorly served by the emergency system we have now. And then lastly, continued funding and legislative action are needed to implement comprehensive crisis services. So thank you everyone for your attention today, and I hope you enjoy the rest of your conference.